Okay. So
Let me make you co-host in the meantime.
yeah, that'll be helpful.
Yeah, okay.
Okay. Yeah.
Okay,
You can
so
start.
may I ask for request for
Screen.
the remote control from you?
Yes. Yeah, done.
Okay, so these are the
So
MRI.
we start now. It's like okay, 5 minutes from your side. So who is I will only keep the time.
So Dr. Ruby will be keeping the time.
Okay, great. Please start.
So these are the brain T2 wetted images. I'm just scrolling through the images. To get some idea, and then I will start. Okay, so while scrolling through the images, I can see the ventricles are not dilated. I don't find any evidence of T2 hyperintensity. Okay. So I will start systematically coming back. I can see there is some hyperintensity in the region of suprasellar region and this perimesencephalic region areas. Other than that, I don't see any other evidence of any brain parenchymal abnormality, no ventriculomegaly, no midline shift, and mastoid air cells are normal. I don't see any abnormal signal within the visualized orbits and paranasal sinuses. So in my routine practice, I would like to have a look on other images like FLAIR for comparison, if I find anything abnormal there.
Okay, you want flare?
Yes, please.
Yeah, you can scroll.
Okay, so scrolling through the FLAIR images, I can see there is an area of
Okay. What are your review areas? So what is your impression in this? Like 2 sequences you have seen, right? What is your impression?
So I have seen 2 sequences. I don't see any obvious abnormality other than few areas of T2 or flare slash hyperintense signal probably in this region.
You can ignore that. So what are your review areas?
So my review areas for the brain are, I'm in the calvarium. I will start from the calvarium. I don't see any evidence of any
No, only the brain
no.
parenchyma.
In the brain parenchymal, my review areas basically are any intracranial mass, any
Mass is
hemorrhage,
not a review area. Okay.
I mean,
Anyways, I'll help you in this case. Okay. Okay. You can scroll again. Sorry if I'm not helping you. Okay. I'm conducting more of a like a mock exam. Okay.
yeah, okay. So these are the coronal T2 wetted images. I'm just scrolling through the images to get some idea of any abnormality. Basically, I'm looking for any abnormal signal. The ventricles appear normal. I don't see
Okay,
any.
fine. No problem. We'll move to the another case.
Okay.
And you can see another brain.
Yeah.
Yeah, scroll through, please.
Okay, I'm just scrolling through the images of T2 weighted images of brain axial. Okay. Okay, so the stacking abnormality, I can see there are some areas of T2 hyperintensity in the subependymal regions, and there are some T2 hyperintense foci in the cortical and subcortical regions of brain parenchyma bilaterally. I don't see any evidence of ventricular dilatation. Don't see any evidence of brain parenchymal lesion or any specific abnormality, especially centered over these ventricle area in the foramen of Monroe. So I would like to have a look on flare images if possible.
Okay. On T2, what in what did you find? Anything? Nothing?
As I mentioned, I can see there are some T2 hypointense subependymal areas in these regions.
So, in any impression could you make of it?
And also there are some hyperintense foci within T2 hyperintense with the subcortical regions. So on this image, I'm thinking about possible subependymal lesions, like which include tuberous sclerosis with cortical tubers and subependymal hematomas. So I need to confirm these findings on FLAIR and then post-contrast if possible.
Good. That is how you have to, because you have to earn the next film. You cannot just ask for another film because you are wasting time of the examiner also. Understood, right?
Yeah.
Scroll through. Because you know it, but you are just delaying the delay saying it.
Yeah, so these are the FLAIR images which confirm my findings of T2 FLAIR areas of hyperintense foci, which are scattered throughout the brain parenchyma in the cortical and subcortical white matter regions. So, and some high subependymal region T2 foci as well. So, I mean, these findings are consistent with possible, subependymal hematomas and subependymal and cortical tubers, which are my top differential would be tuberous sclerosis. However, I don't see any evidence of any enhancing. So I would like to have a look on the T1 post contrast to see if there is
I do not have the post contrast, please.
Okay, I don't see, however, any evidence of subependymal giant cell astrocytoma, which is an association with these lesions. So other if this is a case of tuberous sclerosis, my suggestion would be to scan for the kidneys to look for renal angiomyolipomas and also
what scan will you do?
Renal scan, renal ultrasound, and then we can go for this scan of the chest scan to rule out underlying lymphangiomyomatosis, and also for cardiac rhabdomyomas, we can have cardiac imaging like echocardiography, which are the associations for these.
Okay, you can scroll.
Post-contrast CT scan of the abdomen. I'm just trying to scroll through them. Just sorry.
Can you repeat again?
Post-contrast CT scan of the abdomen.
Again, repeat. It's a post contrast. Are you sure?
I think this is non-contrast examination. Sorry,
Yeah,
I
be
would
very
like
careful.
to take it back.
Mm.
So I'm just trying to scroll through the images, and the striking abnormality which I find is in the lower pelvis. I'm just going to have a general look, and then I will start commenting. Okay, so I can see there is an area of bowel which is showing dilatation with pneumatosis and and associated fat standing in the surrounding area. And I'm just trying to make out which part of the bowel it is rising from. I can see there is some fluid in the pelvis as well. So it looks like to be part of a large bowel, and there is I can see some hyperdensity as well, hyperdense area as well. Which might be related to previous contrast in the bowel. However, I would like to have a look on.
Are you sure it's related to the previous contrast? Like what else would you find if it was a previous contrast?
I mean, we would find other contrast in the other bowel, which I don't see. But I'm suspicious about, can this be a focal area of any hemorrhage as well, which is a other possibility.
So in that case, what would you do?
So
if it is a focal area of hemorrhage, what would you do? Like how would you know it's a hemorrhage?
So in that case, I need to repeat the contrast with arterial phase imaging to have a look and confirm.
No, you can measure the density, right, for the first thing.
And yeah, in the first instance, we can measure the density and see.
So what is the density?
The density looks like to be calcification log. I mean,
no, you can measure it, right? You can see it. Yeah, you can just put an arrow. Okay, that'll just help you. Just a second, just don't move the arrow. Okay, now you can see the values like 200, 400. Okay, here on the left screen. So that's a calcification. Okay,
so that looks like consistent with calcification. So coming back to this abnormality,
so if it just for the sake of discussion, if it was a contrast, what would have been the value, HU value?
I think it should have been in the regions of like
600,000, like that. No, not less. More.
Sorry, 600 for above. Yeah.
No problem. Yeah. So what do you think? So how do you proceed with the case now?
So first, I would have to look on the lung windows to confirm if there is any focal area of perforation. Need to rule it out.
Okay, please see. I'll help you with it. Okay.
Okay. I don't see any free air. However, pneumatosis is still there, and I'm just trying to have a look on the rest of the. Yeah, I don't see any evidence of portal venous gas or any pneumobilia. Okay, so my concern for this appearance is a possible focal area of, perforation, possible localized perforation or pneumatosis involving this region of the sigmoid colon, which appears dilated, and it may represent underlying possibility of underlying mass should be considered. So to take it further, I would need a post-contrast, contrast enhanced examination.
Okay, I'll do that also. So you told it's a sigmoid. Anyways, I would in an exam, right? If you don't know this, you can ideally what we do in our routine practice is we reformat the images and see. Is it? So in the
Yeah,
exam also you can say that.
reformat images available,
Yeah.
that I would like to have a look
Please
on
do
that.
ask for it because that will help you in knowing localizing the bowel. Okay. In abdomen, you can anytime ask it. If the examiner thinks it's not important, he'll himself will tell it's okay, no problem. But in this
Okay,
case, it will help you.
okay.
Take the reformat of coronal. Just a second. Just a second. I'll just push this up a bit because that's not important for us. Okay, you can scroll again.
Mhm.
So you told it's a part of a sigmoid, right?
Sorry, so I would like to take my statement back. I think it is a part of the small bowel, probably distal jejunum, uh, and it is showing some dilatation, and there is pneumatosis and some associated fat standing. So my differential for this appearance for aneurysmal dilatation is lymphoma is a consideration for this appearance. And
Okay,
however,
what was that the calcification thing then? If it is a lymphoma or anything.
I'm looking.
Sorry, I do not have the contrast for this study, but what is that calcification thing? Okay, I'll help you. Can you trace the cecum for me?
Okay, so I can't see the cecum in the usual position where it should be. So I'm thinking about, is this a case of malrotation with possible cecal involvement? And this is the ascending colon.
Which is the
So
ascending colon?
this whole
Yeah. Okay.
area, and which I'm seeing dilatation and associated standing. So I need to again have a look on the axial and reconfirm my findings.
Yeah, you can. What do you want to look on the exit?
So basically, I will be looking for tracing the duodenum, whether it is crossing normally or not, which I believe it is not. So I need to see it on
You can change
the.
the window. It'll help. Wait, I'll have this one. Just a second. Okay. And what else you look? We'll move
And
to
the
the
other
next.
thing we look evidence of SMA and SMB, which are I mean SMB is on the right of the SMA, which is again consistent with malrotation. So
Trace it for me.
so this is SMA.
Okay.
And this is SMB.
Which
And
one?
there
Which one?
is this one.
Yeah. Okay.
And there is reversal of the normal ratio, which should be on the right and it is on the left.
Great.
So
So your
this
final
is again.
diagnosis is?
So my final diagnosis is an ascending colon I mean, involvement, which is showing increased dilatation with associated pneumatosis and fat standing. It can be infection, it can be malignancy. So although I don't see any evidence of enlarged lymph nodes. So
What was the calcification thing? If anything we could say, what was the calcification? You can just leave the mouse, please. What was the calcification thing? Any idea?
calcification, I'm not sure. I'm not sure.
Okay, no problem. Oh, unfortunately, name is coming. This wait, just a wait. Okay. Yeah. Now you can see anything?
Yes, I can.
Yeah, you can describe.
Sorry. So this is the frontal radiograph of the left shoulder. I can see there is an expansile, large expansile lesion involving the left humeral head, which is showing internal areas of multiple septi, and there is associated cortical irregularity as well. And I don't see any evidence of associated periosteal reaction.
Yeah, 20 minutes are over.
Okay, so
This is the last case, no problem.
And the rest of the visualized bones are normal. So my differential for this appearance is like since it is expansile aneurysmal bone cyst is my differential, and then fibrous dysplasia can be a possibility, but it is more metaphysical, and also since it is showing some internal matrix which is hyperdense or internal septations, so telangiectatic osteosarcoma can be one of the differential as well. So to take it further, I need to compare with any previous imaging, and if the patient has presented with pain, then I don't see any evidence of fracture, however, but I need to, evaluate it further with MRI to take it further.
Okay. Can just describe this fast so that we'll have 5 minutes discussion. Just a second. T2, you can take the T2. Okay. T2 and T2 spare. You can, all the sequences you can look if you want. Yeah.
Okay. So looking at the these are T2 vector images. I can see there is this lesion is showing, more T2 heterogeneous appearance with mixed areas of internal hypointensity and then high signal, and I can see there is associated soft tissue component as well. The underlying bone is, I would like to have a look on the T1 for the underlying bone, which appears.
Yeah, please see. Yeah. That's not even.
Sorry.
Yeah, that one. Down. Okay. Up to you.
Okay. So underlying bone is involved, and I think these are some fluid levels, but which are disorganized. And it is very heterogeneous appearance, and these are not typical of aneurysmal bone cysts. So I would say my other possibility, like telangiectatic osteosarcoma, is my consideration in this with these appearances. I would like to have a look on post contrast if these are enhancing.
Do not have the post contrast. So your differentials are last. telangiectatic osteosarcoma, and anything else?
Uh,
Aneurysmal bone cyst.
aneurysmal
That's what
bone
you said.
cyst,
Is the age matching for ABC? Did you see the age? No. It's 31 years. Okay.
31.
In 31 years, ABCs
I
can
think
occur?
ABC we can have ABC in 30 years, can we?
Usually, no. Yes, if you're asking me strictly, yes, we can, but there will be secondary ABC, not the primary ABC, which is here. Like the ABC, like GCT transforms to ABC, even fibrous display transforms to ABC.
Yeah.
That can happen. Okay. Okay, fine. We have 5 minutes to start discussion.
Okay.
Okay. You're fine in the MRI. In the X-ray, right? I would have recommended you to describe everything. Did you describe the transition zone? I don't think so. Transition zone is very important. In that, always remember, like whenever a a skeletal MRI is there or a bone tumor MRI, there are
Yeah, it
5,
is a
6
wide
things.
zone of transition, definitely.
No, this is narrow, right? You can see here.
But
This is
no,
sharp. This one we cannot say because see, there is no zone, right? There's no parenchyma here.
I mean, I agree. This is sharp zone, but what this whole mass is like, it is not. We don't see where it is starting, where it is ending, isn't it?
No. What? Okay, fine. If you're asking me, it is involving subarticular region and everything. But if you're asking here transitions, okay, we can. What I'm saying is, you need to say that transition zone here in the inferior aspect appears narrow or sharp.
Okay.
And rest of the things, I cannot find any bone marrow or any bone cortex. The bone cortex is irregular and it is expansile lesion with subarticular extension. So this is most likely to be a locally aggressive giant cell tumor.
GCT.
Okay, because anything expansile, and this is not eccentric, and this is not even corresponding to the age. ABC usually lesser age, and also it will be more of an eccentric thing. Okay, and you don't have a simple bone cyst to say like fallen fragment and all. Usually they say fallen fragment is not seen in each every case, but again in exam they show you fallen fragment sign to say it as an ABC, sorry, SBC, simple bone cyst. Okay, so this is GCT. You have to tell the differential, and telangiectatic osteosarcoma was also a good differential. Okay, so how will you differentiate that? Okay, another important. No, that fluid levels will help you. That is only histopathology. Okay, remember that. And you have to always when you're concluding the case, you have to say where you'll refer, what you will do next. Okay, you have to refer this to a bone sarcoma in detail. Always remember it.
Yeah, I mean sarcoma team referral and all that stuff.
Always in your description, in any case of a Viva, try to go till the referral part. Okay, even if you have not described it fully, at least you will get points in that. They will see, okay, what this guy will do with this case. Okay, in that way you have to always tell, and you can only differentiate this on a biopsy. Okay, on an X-ray or an MR, you can say it is aggressive or non-aggressive lesion. Okay, lucent or non-lucent. That's it. So the other case, 5 years, right? Yeah. This one, anything can you see here on the coronal? Very characteristic. Okay, somewhere I kept that image also, just to help you. This one, what is this? Moose head appearance or a Viking horn appearance? Or
oh, okay.
What did it strike?
I heard of it somewhere, but
okay, racing car sign. These days they say racing car sign.
Racing car, and but are these typical like racing car sign or
racing? No. Okay, forget about the signs. What is more typical? You can see the ventricles are parallel.
These are parallel and corpus callosum and all that.
Yeah, where is the corpus callosum?
Exactly. So I should have seen the sagittal. It would have been more helpful, but anyway. So yeah,
but no one will give you sagittal in the exam. No, remember, no one will
give you everything on the exam. You are right. You are right.
Yeah.
It should be picked up on this image.
Yes, you have to. Just remember, okay? Especially when I put you coronal, right? You have to pick it up. Coronal is this thing is a very classic Viking horn, because anywhere you just see normal brain MRs on the coronal, they never will be like oblique, slanted. Okay, they'll be like on the more horizontal. They are coming towards each other or towards midline. just because
Yeah,
there is no corpus
yeah.
callosum there. Okay.
Yeah, yeah.
And what are
Perfect.
those bundles called? Robust bundles. Okay, that also
Robust,
they ask in the exam.
robust buttons.
Okay,
Thank
we
you.
can see this.
Thank you.
So is so smiling. These are two eyes. Okay. And one more case, I
Smiling
think
at me.
this
Yeah.
one. Yeah. So and this was spot on. You knew it. Okay, when you saw it, you knew it. So you tell it as early as possible. Don't wait for like I'll see, or else what ideally you have to say is I'll confirm this on T2 flare. On T2, it looks to me like a tuberous sclerosis.
Yeah.
So that time, no, the examiner moves on to the next case instead of wasting time here.
Okay. Right.
So you get more marks. This one, this was a difficult case. That's why I kept it in the middle. Okay, but still with the common approach, you'll get it. Always, whenever a CT is given, CT abdomen especially, okay, when you know that, okay, many of the times there'll be no pathology seen, but in this case, at least you are seeing a pathology. Then you have to always go and see where is the appendix or
Right.
where is the
Right.
ileocecal junction. Any
Yeah.
CT abdomen, remember that you go first and see for the bowel loops, ileocecal junction. Half of the work is done because most of the pathologies are there only. Terminal
Okay.
ileum pathology, Crohn's, whatever pathology you know of the bowels, most of them they are located in the ileocecal junction,
Yeah. Right.
especially
You
in
are
the
right.
exam setup or in the rectum or somewhere. Okay, so always whatever plain or contrast, go for the ileocecal junction.
Ileocecal junction.
Because if you had that approach, right, I'm trying to develop just the approach. So if you had that approach, you'll never would have gone or swayed and would have saved time.
Yeah. You are right. You
Okay,
are right.
so now where is the appendix? This is the appendix. Okay, this is an acute
Oh, okay.
appendicitis with an large appendicolith. Okay,
Appendicolith.
yeah, the inflammation is all because of the appendicitis which is going on there. And this all that I would not say it is impending ischemia because you have to give contrast, but yes, there is a pneumatosis along the cecum. Okay,
Yes.
this was ignored. And very important thing, this is malrotation. This is not malrotation, this is non-rotation. Okay, remember.
Right.
Okay, this is non-rotation. And see how it is how will you know that there is no okay, what is the latch procedure? Just asking. And you know the latch procedure? In that, no, they will do appendicectomy. In this case, appendicectomy has not been done. Okay, means for example, just for a bit higher level, I would have said that this is just a malrotation and the patient has come post-operative. But in post-operative case of LAD, you will not find appendix. Understood? So this is a
Right.
non-rotation,
Right.
not a post-operative case of malrotation. Understood? This is not, the patient never knew of it.
So LAD's procedure is done in malrotation, I believe.
Exactly. This is not a see what I was trying to explain is you would have got confused whether this is non-rotation or a post-operative case of LATs in a
Sorry,
malrotation.
how do we differentiate
Exactly.
between non-rotation
Exactly.
and malrotation? Is this the only criteria? Like, if we find the appendix, then it is non-rotation?
Not like that's not the criteria. I'm talking about the post-operative thing. The criteria for malrotation is that you will have more like it will be more up. Okay, and you will have like I forgot it will be more anterior instead of
It will
coming
be
to the
more
right.
anterior. Okay.
More anterior. The SMV will be more anterior and all.
Right.
Okay, incomplete rather than a complete reversal.
Rather than complete reversal, it will be like in the midline.
Yeah. Okay. Thank you, Dr. Asad. I think your time is over.
Thank you, Dr. Aejaz. Thank you.
No problem. Sorry if I was a bit harsh, but that's how the exam is. Okay. Personally, I try helping people, but
It's
the exam setup,
absolutely
right?
fine. Like,
It's how it goes. There'll be a lot
we
of
have to
silence.
drill ourselves like this.
Yeah, there'll be a lot of silence. Okay.
Yeah.
So just remember that, and you should hold on to your nerves.
And
The
some
examiner also
examiners
knows it.
are even harsher than this.
Yeah, I do agree.
You were very kind.
No, I wasn't. Anyways, all the best, Dr.
Okay,
Asad.
thank you.
You are doing good, but just the technique, right? Just remember, go on to the basic technique, so you will not miss things.
Yeah.
You know everything, but only thing is you should follow the technique. Okay.
Thanks.
Okay. Thank you. The next candidate, please.
Yeah, it's me, Dr. Noura.
Okay, just a second. Okay, you can see the CT thorax now.
Yes. Mhm.
Yeah, okay, you can continue. You
So,
want okay, you can control it. I think remote control, auto
uh,
accept all requests. Yeah,
yes.
now you can accept it. Yeah,
Okay. So I've been provided with.
just relax. Okay, you can get the cases if you just relax and go through.
Okay. So
Don't
I've
worry.
been provided with axial images of non-contrast enhanced CT of the thorax. I'm just going from up to down.
Can you just leave your mouse once? I'll just help you.
Yes, please. I left.
Yeah, I'll just do this up. Okay, now you can scroll.
Okay, now I'm in the mediastinal window, so I'm just looking to the heart shadow within normal, and the solid organs in the upper abdomen looks unremarkable. I'm going, okay. So can I haven't seen any lymph nodes. There is some atherosclerotic calcifications in the wall of the aortic arch. However, I haven't seen anything. Can I go to, okay, I will look to the bone structures also. I'm just looking if there is any problem in the bones. I haven't seen any lesion in the bones. And around, I will look again to the surrounding tissues. I'll have another look. Okay. I'm just, yeah, scrolling again.
Okay, you are commenting on the bones. Can you just look at it again once, please?
Yeah, I'm trying to scroll, but it's stuck in my hand. Okay, I will look
No
to
problem.
the bones again. I think there is some, I think rib fracture on the right side. It is no.
Do you think it's the right thing to see comment on the bones on this?
No, I need a bone window. This is
Please,
mediastinal window.
yeah, you have to do. You have to ask me, right?
Okay, I want the bone window. Yeah, I'll
Yeah,
be so
please.
happy if you give me. Yes. I was afraid to ask you.
No, you should never be afraid. See, remember, you have to be more confident in the exam, even if you are
Okay.
selling wrong, because the examiner will help you if you tell. How would I know that you are thinking that, okay, I want to see bone window? That's how it is.
Yeah. Yeah, I'm just having a quick look to the bony structures.
You're pressing a lot, okay? Keyboard, just press and hold for a while. Or else you can use the scroll button. That will help you more. You can use the mouse to scroll. You can see the scroll bar here on
Yeah.
the right side. You can use this also. That will also help you if you
Okay.
want.
Well, I haven't seen any remarkable thing in the bones.
Just focus again. This patient had come to me in the same way, chest pain. That's it.
Okay. Something maybe wrong in the right ribs. I think there is some irregularity in the right anterior
Where?
lower near the liver. Yeah, here.
Okay, you can ignore the liver. Now you are seeing the bone window, right? You had
Yeah.
asked me for the bone window. I helped you with the bone window. Now you have to comment upon the bone. You should not go to the liver. That's how the exam goes.
Yeah, I'm looking to
And
the
I'm helping you and I'm giving you cues. Please see the bone. Please see the bone.
yeah. Thank you for your help.
Yeah.
There is some irregularity in the ribs here and
That
there.
is the costochondral junction and that could be the movement artifacts. See the vertebrae?
Okay.
I hope someone is keeping time. Acha, Ruby, right? Okay.
Yeah.
Okay, I'll help you again. Okay, yeah, you haven't seen anything on the axial. Okay, I'll help you with the sagittal because we have don't have time. Yeah, you can scroll.
I just want to reach the vertebral level. Yeah, there is some diffuse osteopenia, and there is some depression in the end plates of the mid.
You can ignore it. You can ignore it because osteopenia is there, so there will be some depression. That's okay.
Okay.
What else within the osteopenia are you able to see? Anything else? Nothing.
No.
Okay, just a second. I'll help you.
Okay.
Here you can see anything.
The sternum is
Vertebrae.
depressed.
Forget about the sternum.
Vertebrae.
Vertebrae, are you finding anything?
There's densities here in the heterogeneous intensities, maybe lytic lesion.
Okay, fine, no problem.
I haven't
I
seen
need
it.
to help you with. Okay, I'll help you. I'll give you this.
Okay, so there is multiple lytic lesions are in the bony pelvis, separated on both sides and in the proximal femori. This gives me the evidence of diffuse lytic lesions in the bone, and as the patient is old in age, so my first diagnosis could be multiple myeloma. However, I can't differentiate it from metastasis, lytic metastasis. So multiple myeloma or metastasis, and my third possibility could be lymphoma. So I will relay these findings immediately to the referred clinician to be discussed in the hematology MDT for skeletal survey and for Benz-Jones protein and other
MRI. You have to tell MRI.
and we'll
You
ask
will do
for whole
MRI.
MRI. Yeah, whole body MRI, as it is available nowadays in every. Yeah, there is diffuse infiltrative signal changes in the axial images of the lumbar and thoracic vertebrae, which confirms my first suspicion of multiple myeloma. This is diffuse.
In this, anything in T1 you want to tell anything more?
In T1, there is
anything more additionally MRI is helping you with, which is very important.
Some loss in height in the vertebral body and
yes. Where?
Yeah, these multiple small.
Okay, you can click and show to me.
Okay.
Where?
Here, and the third level, there is some.
Sorry, just a second.
L3, I said.
L3, right? Yeah. You have to mention this. Okay, these are the fractures which are okay. Yeah, bridge compression fracture that you have to report in this one. So if you miss that, you'll lose marks in the exam. So MRI helps in knowing the osteoporotic or what are the fractures. Okay, and in the and also helps in MRI helps in the follow up also.
Yes, of course. Yeah.
After the treatment. Okay. So we'll move to the next case. Okay, you can see.
Yeah. So I've been provided.
You can just scroll. These are the two images. Okay, 1 and 2. You can just see and comment.
Okay. So this is two orthogonal views, lateral and I think axial of the ankle joint of the right side. I can see there is increased sclerotic area in the ankle with irregularity of the cortex. And as I will go to the other, there is a focal hypo or lytic lesion which is surrounded with the massive sclerosis in my first impression is a chronic osteomyelitis, or it is sequelae of osteomyelitis in this region. And I will relay these findings to the endocrinologist or the referred clinician.
Endocrinologist for what?
Because he may be diabetic food and maybe he has diabetes and recurrent infection. However, I can't see any soft tissue swelling or any evidence of infection in the surrounding soft tissue. So this is a chronic sclerotic changes surrounding a lytic lesion. It could be sequestered sequestrum of an old infection, osteomyelitis. Yeah. I would like to see CT or MRI of this patient just to see the
scroll down.
better. And if there is previous images, it's better to see the progression of the condition.
Scroll this one.
Okay. I'm just going down. So this is CT images. Yeah. Well, yeah, there is a rounded lytic lesion which has a hyperdense content with the surrounding sclerosis. This gives me the evidence of sequestrum within the lytic lesion and surrounding sclerosis. My other differential for this, it could be osteoid as osteoma. However, I will look to the clinical picture of the patient if he has any night pain at night, and if it is relieved by non-steroidal anti-inflammatory.
What features are suggestive of osteoid in this case?
There is a dense nidus and surrounding sclerosis, but this is not most probably due to chronic osteomyelitis with a sequestrum within this lesion.
Don't go to that route. It's not an osteoid. It's a very classic case. In classic cases, you should not give differentials. Okay.
Okay, this is a typical.
Typical chronic osteomyelitis you are saying. So what are the three things you have to show when you link chronic osteomyelitis to the examiner?
Yeah, so I will relay these findings and will recommend.
No. Show me what are the three features of chronic osteomyelitis. What we see.
There is this is the sequestrum in the middle, and the involucrum and surrounding sclerosis, diffuse sclerosis, and there is no active infection around in the soft tissue.
And another cloaca. Where is the cloaca?
Yeah, there is no cloaca here.
There is no cloaca?
No. Yeah, this is the cloaca. This is the cloaca goes up.
Yeah, that one and down one also. Okay. Never say no. When the examiner is asking you something, don't say no, because there will be something there.
Yeah.
Okay.
Yeah.
First look at it and then tell.
Yeah, right.
Okay.
So there's a cloaca, involucrum, sequestrum, and massive sclerosis surrounding the lesion. And no active inflammation.
Which is the dead bone, sequestrum or involucrum? Because that's what they ask in the Viva. Okay. Tell me, what is sequestrum is what?
Sequestrum is the dead bone.
Involucrum is?
Involucrum is the vital bone.
Okay, great. So what do you do for this patient treatment? Any idea you have to get additional marks?
I will drainage and
you will not drain it. You will not drain it. You will refer to the orthopedician who will do debridement. Use the word debridement.
Debridement, yeah, debridement.
Okay, because these are all like buzzwords or the keywords. These are very important to tell in the exam.
Yeah.
Understood, right? So use the word debridement. There will be debridement of the sequestrum because it is a dead bone and it cannot be healed by the antibiotics because the antibiotics don't reach it. It's an island. Okay. There's no vascular supply. The involucrum, sometimes they remove, sometimes they don't, but that sequestrum has to be removed. Without that, there will be no chance of healing.
Yeah, sometimes even they put antibiotic within the debrided.
Yeah, exactly. Yeah. So you know all, but you have to just express it and use the right words.
Okay.
Okay. You can see the knee.
Yeah, I will.
Please proceed.
Yeah, so this is sagittal T1 weighted images of the knee. I can see some pleural effusion within the knee joint, and I'm going to look to the the meniscus. I can see there is a linear hyperintensity within the posterior horn of the medial meniscus extending to the inferior wall. This is keeping with the tear in the meniscus, medial meniscus, posterior horn. The lateral meniscus looks intact. I'm looking to the cruciate ligaments, ACL and PCL are intact. I will go to the bone structures. I can't see any remarkable thing here. And in the surrounding tissue, the quadriceps tendon and patellar tendon looks intact. In my routine practice, I would like to go to the sagittal T2 and coronal T2 to delineate the situation. Till now,
this is sagittal T2, I believe.
T2 fat sat.
Okay.
Yeah, because I can
see. I do not have the sagittal fat sat. I have the PD fat sat. You can take the PD fat sat. Just a second. Okay.
Okay. So till now, I've seen effusion and medial meniscus tear. And I want to look to the bones better if there is any, okay, there is double PCL here, yeah. And as there is tear in the medial meniscus, so I'm suspecting of bucket handle. I would like to see the coronal or axial images just to know if the segment, just to see the segment, the flipped segment better. So yeah, this is double.
Are you not seeing it better here?
Yeah, this is
You are
PCL.
seeing it good. Yeah. But anyways, no problem. Coronal, you can see
PCL,
the
double
coronal.
PCL sign, which is keeping
Yeah.
with
You can scroll.
bucket handle tear of the medial meniscus. Yeah, it is here, seen very well.
So confirm the like final. So it is a bucket handle tear. That's it, right?
Yeah, it is.
And pertinent negatives also you have to tell. What are the pertinent negative in always in a bucket handle tear?
Well, I can see ACL tear or PCL
Good.
tear. And there's
That's
no
important.
medial and lateral collateral ligaments are also intact. I
Yes.
can't see any.
What is the treatment?
The treatment is surgical in this case because it is flipped and displaced segment or tear.
Okay. Okay. You can scroll.
Okay, I've been provided with axial images of brain MRI. This is T2 weighted images. I'm going from down to up. Okay. There's multiple rounded nodules or lymph nodes in the neck, more on the right side in the region of the parotis gland.
Where?
Just go back. Here, maybe here. There is,
Okay.
yeah, extending to the pharyngeal space and submandibular space. This could be, yeah, there's multiple hyperdense lesions or
Dense.
hyper intense masses in the region of the submandibular and parotis, extending to the base of the tongue and parapharyngeal region on the right side. And there is multiple lymph nodes on both sides. This looks like invading all the soft tissue spaces.
I think what you need to do in such cases is you have to go through the whole sections once, then you need to start speaking. So just go through the whole thing and think what it can be, then you can explain.
Yeah, right. So I will start from the upper thorax. Then now the brain images comes to me. I can't see anything.
No, you need not speak. You can just go through it once for like a minute. Then you can describe it. That will be more helpful in an exam. Okay. That will help in localizing what you are thinking. You can take a minute in an exam, not a minute, 30 seconds, yes, to go through the sections.
Yeah, right. So multilocular hyperintense lesions on the right side of the neck, specifically in the submandibular and the parotis and the gland, extending medially to the parapharyngeal and to the root of the tongue. And they are ill-defined in outline. I would like to see the other sequences just to delineate.
Which one you want?
Maybe contrast enhanced CT MRI will be helpful. Or
see, whenever you are asking contrast, right? First you should ask T1 because contrast will be with the T1, right? So just look at the T1, then I'll give you contrast.
Good. So the lesion.
Okay, this is a plane. This is a plane. Just look at it, then I'll give you a contrast. Or else just a second.
Okay.
Okay, this is plain and this is contrast. Okay,
Mhm.
can scroll. And this
Oh,
is
the
coming in the middle. Okay,
area,
yes.
yeah, to the interest, yeah. There is a heterogeneous enhancement. Is there any necrotic areas within it? Because what my first impression was, it is an aggressive lesion. So either neoplasm or infection. Uh, uh, the bones, I'm looking to the bones. Is it bony based lesion? No, the bones looks intact because the bone marrow also looks normal signal intensity. So there are multiple multilocular lesions of heterogeneously enhanced. This
20
is,
minutes are over.
yeah, this gives me a possibility of neoplasm more than infection. It is an aggressive lesion in the area of the neck.
So how will you differentiate it's a neoplasm or an infection?
Well, in infection, there is much more abscesses and fluid collections. I can't delineate the abscesses here. I can see some necrotic areas within the solid
Is
enhanced.
abscess a necrotic area?
No, this is not abscess. This is, yeah, it can be an abscess also. Well, because it is very diffusely extended, so it can be infection and
See, you should ask the examiner the clinical picture. I would correlate to the clinical picture, whether the patient has fever, whether the patient has pain, redness. Okay, you should ask the examiner. That will help you.
Yeah, I will
So
look.
yes, the patient had fever, the patient had a lot of pain, he's had excruciating pain. Okay.
Yeah, because it could be both of them. So I will look to the inflammatory markers.
So where do you think the infection is coming from or anything? Any clue is there in this? It's a bit difficult, but yes.
Yeah, it could be
And
from,
what this infection is called? It's multi-compartmental, but usually what this infection is called is when what do you do next?
I will look to the vascular structures because I'm suspecting of Lemierre disease because in these diffuse inflammations, the vessels could be thrombosed, specifically the venous vessels. So that's why.
Okay,
I will ask-
unfortunately, I do not have that, but that's a good idea.
Yeah.
Okay, what are these? Okay, just you stop at that. What are
Maybe-
these? What are these?
These are air bubbles, so it could be aerobic infection also.
Air
Within
bubbles or
aerobic infection or calcification.
air bubbles or calcification. Then what calcification?
Maybe calcification, calcified necrotic lymph nodes, maybe infected TB.
Okay, we'll come to this later. Okay,
Yeah.
I'll just show one last case, then we can. I think, yeah, because I have discussed with you while we are going, right? So
Okay, thank you.
I'll just show one last case too. This one.
Okay, so this is frontal X-ray of an adult patient. I am looking to the.
Oh, sorry, just a second. Sorry.
Okay.
I don't know why it has. Okay. No, resume share. Pause share. I don't know why it is showing the names and not. Just a second.
I haven't read anything.
No, you haven't. But it's been recorded, right? It's not good to share the names. Anyways, unfortunately, okay, we can just abandon this case. So, okay, this case only we'll discuss.
Okay.
Oh my God. Just okay. This one, right? Okay. This, see, when it is multi-compartmental and all, it will be usually infective only.
Yeah.
First of all, to suggest things,
Okay.
because no tumor will be so big generally. Okay. So, but anyways, you have to ask the examiner regarding the clinical picture. So that is the first point. So you are right in telling referentials, neoplasm or infection. And what are all these? So where is the focus of infection? In the neck, usually, have you heard of Ludwig's angina? Have you heard of it, Ludwig's angina?
No, what is Ludwig?
Okay, Ludwig's angina is a infection which is in the submandibular region, which extends into the neck. Okay, it's a medical emergency.
Okay, thank you.
Okay, yeah, this is Ludwig's angina, but it is a very severe case of Ludwig's angina, which is crossing the compartments. Okay. Usually the cause of Ludwig's angina is a dental abscess or a dental extraction. But in this case, you can see nice black things, right? These are all calculi. These are parotid gland calculi and submandibular gland calculi. So there was a chronic sialolithiasis infection which has caused all this infection. Okay.
Good. Thank you. Very
And
good.
the most important point which you have to tell the examiner is, I would pick up the phone, call the emergency team, because this patient has to undergo as you have to secure the airway either
Yes.
by tracheostomy or by ET. ETU is difficult because you cannot put, you can see that it's very narrow. So you
Yes.
have to, most of the cases of this one Ludwig's angina go into tracheostomy. And Ludwig's angina has come in the exam. Okay, remember it.
Good. Good.
Because any infection they will put, and this is an emergency case, so you have to be aware of it. Usually it will be, they will tell you history of dental extraction and all in the real scenario, but in this case it was very nice. The second most common, what I have read is, second most common is the parotid and the calculi causing sialolithiasis, which has caused so much infection. Okay.
Thank you.
Salidinitis,
Good case.
basically what I meant. Yeah.
Okay.
Okay, any cases which we have to discuss, like for you? Any case which we didn't discuss? Any idea? Nothing, right? We have done the osteomyelitis and multiple myeloma, right? You are seeing the bone lesions. Why were you like so thinking like, well, the bone lesions were not very clear?
Yeah, it was. There was lytic lesions and osteopenia. Maybe because I was very excited as it is the first case. Then and the
Okay,
other
don't
strict.
get frightened.
Yeah.
Okay.
Then I said Bismillah and started.
Okay, you're doing well. Just anyways, exam thing, it will be difficult. Okay, don't worry.
Okay, thank you.
Okay, I think your time is up. Yeah, it's up.
Oh, yeah,
Okay,
thank you
thank
very
you.
much. Good cases.
No problem.
I will
Thank
stop
you.
the request.
Who's the next person?
I'm
Okay.
next.
Ruby, yeah. Mhm.
Acha, Ruby. So who is taking up the time?
I
Dr.
was.
Asad, are you there?
I
Okay,
was.
you will. Okay, no. Okay, sure. Okay, you can start, please. You can scroll.
Okay. I need to ask for remote first.
I have auto accepted all requests. You can.
No.
Is it not there? Okay. I don't know what's happening. Your name is Ruby, right?
Yes.
Now you can do it.
Okay.
Yeah. I have given most of the cases a scrolling part because in the exam, the scrolling part is the most difficult. Many people who have done the previous sessions, they know that the scrolling was difficult. Okay. You can scroll.
Okay. So these are MRI brain images, T2 weighted sections. And I could appreciate there is an abdominal signal intensity is seen in the right frontal lobe with significant surrounding edema and mass effect. And there is an well-defined, roughly rounded low signal intensity, high signal intensity with surrounding hypointense rim. And there is another well-defined rounded high signal intensity is also noted in the cortical subcortical region with significant surrounding edema and subfalcine herniation and the mild midline shift and compression over the left lateral ventricle. So I would like to assess the contrast enhanced study and the diffusion weighted images, as I'm suspecting this could be an abscesses or this could be a metastasis.
Okay. You want a contrast, right?
Yes. So I'm provided with the T1 contrast enhanced images, and these lesions shows at least there are 2 lesions. And these shows peripheral ring enhancement and adjacent dural enhancement as well. And again, there is again mass effect and midline shift. And I'm quickly going through the images to see any other lesion. And there's no evidence of any lesion in the posterior fossa, and no obvious spiky meningeal enhancement in the rest of the brain parenchyma. So still my differentials would be either an infection or it could be a metastasis. And for that, I need to assess the diffusion weighted images and detailed history, if there is any history of fever or raised inflammatory markers. And in my routine practice, I'll review the paranasal sinuses as well, and the mastoid and middle ear to see any evidence of associated infection. And history of any previous, any known primary.
Yeah. I started with T2. Can you just look at it again so that you can just narrow it down to something else?
Okay.
So what are your differentials basically? You told me Mets. You
Mets
told me
and
abscess.
yeah. Or these could be cavernous malformations, but that won't present with the significant surrounding edema. It doesn't look like a primary mass, could be glioma.
Okay. No problem. No problem. We'll move ahead.
Aggressive looking.
Okay, no problem. No, I did not pause. You can see the abdomen. You can see the study? Abdomen?
Yes.
Okay, you can scroll.
CT.
Yeah.
Okay, so these are non-enhanced images of the CT scan of the abdomen. And I'm going from caudal to cranial. Sorry. I'll start from the top, from the cranial.
In exam, right? Don't worry, caudal, cranial, and all. Just tell I'm scrolling through the images, so you'll be on the safer zone.
Fine, fine. Okay. I could appreciate tiny hypodense lesion in the liver, could be a cyst. There is a large
Ignore.
Yeah.
Ignore. Okay.
There is large hypodense mass. Sorry.
No, there is no
It
mass.
was kidney, yes.
Hmm.
Okay. Till now, I haven't.
This patient had come with
found-
abdominal pain
Right.
on the left side.
Okay. Looking at the bowel loop, there is no evidence of any dilatation. The bowel loops appears collapsed. Large bowel is also collapsed.
More
And considering the left side of the abdomen, this patient presented with the abdominal pain on the left side. Okay, I'll follow the rectum up.
Okay, I do not want to waste time. Yeah, I'll give you a coronary format, so that will help you. Okay.
Okay. So I'm provided with the coronal images. The patient having left side abdominal pain. The solid organs are unremarkable.
Okay.
And looking at the descending colon, ascending colon, transverse, all appears unremarkable.
The pain is more
And,
specific in the left iliac fossa.
Yeah, I'm concentrating more in the left side. Okay, can we go back to the axial? I'm more comfortable with that.
Up to you.
Yes.
Sure, sure. Okay. This is a case of testing your eyes. That's it. Nothing else. There are cases which have more specific things. So like this is the test of your eyes or judgment. That's it.
Okay.
If you know it, you will easily tell it. It's nothing like you have to think about it.
I found an
Ignore. Go to the left. I told you left iliac fossa. You remember it? Like remember the examiner's word, what he has told, because that will help you.
Okay, I'm looking for any evidence of fat stranding, any lymphadenopathy, free fluid, any diverticulitis.
Go through all the sequence.
Fine. I'm not able to appreciate any fat stranding
Okay,
in
no
this
problem.
region.
No problem.
I'll
No problem.
quickly just
No, it's okay. It's okay. We'll move to the next case. No problem. See, when the examiner tells you will move to the means it's okay. Means you can go to the next case. You'll get more opportunities. Sometimes no, it doesn't strike to us. Understood, right? However, the good candidate is there. Some cases at that moment it doesn't strike. So it's okay. When the examiner tells, he knows the candidate is good. He just wants to help. Okay, that's how it is. This patient had come with epigastric pain or abdominal pain. Can scroll.
yes. Okay, these are the contrast enhanced images of the CT scan of the abdomen in a patient having epigastric pain. There is rectal contrast is also given as well as oral contrast. And I could appreciate there is intimal flap is seen in the region of the descending abdominal aorta. And I'm going about to see from where it starts. Okay, it is extending through the thoracic aorta as well. Oh, I couldn't get the, yeah. So the imaging starts from here. Okay, so I would like to assess the chest from the arch of aorta and ascending aorta as well. Because
good. Just a second. Just a second. Just okay. Wait. Where is that first? Yeah, this one. You can scroll.
Yeah. Okay, I'm looking at the branches of the aorta as well. There is thrombus in the left subclavian artery. This section is extending. And the intimal flap is seen in the region of the aortic arch. So I think ascending aorta as well. Yeah, I want to change the window to see the flap in the region of the ascending aorta.
Just a second. I'll help you.
I'm going back to confirm the ascending aortic involvement. No, there's no dissection flap in the region of the ascending aorta. So it starts from the arch of the aorta. I'm seeing that it's below the origin of the left subclavian artery. And then, yes, extending into the abdominal aorta. And in my routine practice, I will review all the branches of the aorta to see its further extension and the evidence of any infarcts.
Okay. Are there infarcts or not?
Yeah, can we?
And in aortic dissection, when you have seen it, then you have to score more marks by telling what all the negative points you can tell. Negative or positive. You have to tell whether it's a true, which is a true, which is a false. Even though
Yes.
you know it, we need to tell it. Yeah.
Yes.
I also know which is the true, which is the false, but you have to tell it. Tell me which
Mhm.
is the true, which is the false.
Okay. I would like to assess the origin of, I'm suspecting the true is on the medial side, but I will confirm it more to see the origin of the vessels.
How will you differentiate true and false?
The density of the contrast will be more in the true lumen. The false lumen used to be larger than the true lumen. And usually the major branches like celiac, superior mesenteric arises from the true lumen. And the right renal artery also arises from the true lumen. The left renal usually arises from the false lumen. And other, the obtuse angle. And so there is evidence. There is some dissection. Yeah, the flap is extending into the superior mesenteric artery as well in the proximally. And then that was celiac. Superior mesenteric is fine. Yeah.
That was a cause of epigastric pain. So whenever he was eating, he was getting pain.
Fine. Okay. And now
And this patient, just for a tidbit history, this patient was coming to the emergency every 2 or 3 months for like, he came 3 times in 8-9 months. And he was just referred like that. Then just because he's coming, they did a CT scan. So and then we had this finding. So that's how it is.
Okay.
And he's like quite young, no history of any hypertension.
Yeah, 40-year-old.
So anyways, true and false you have told. So what do you have to conclude the case?
Okay, so this is the I have to see in my routine practice. I'll review the organs for any evidence of infarctions as well. So till now, I will conclude the case. This is a aortic dissection, Stanford type B, and extension.
Okay, I should not help you, but are you sure it's a type B? Why did you say it's a type B? How will you differentiate type A and type B?
Type A extends from the region of aortic arch and then it extends distally into the pulmonary.
It is
Type B
from the arch,
starts,
right?
Okay. I assume that it's from the origin, beyond the origin of left subclavian artery. So I will go back and review that.
Should be very careful. Okay. Anyways, it's type A. You saw that, right? It was coming from the arch. You saw this image, I remember.
Fine.
Yeah.
Yes. So it's Stanford type
That is
A.
that is the reason you are seeing whether it is extending to the aortic root. Okay. Anyways, no problem. Type A, then?
Right. And then it's an urgent referral to the cardiothoracic team for the management.
What they will do?
Surgical management.
Okay. So the other point is, what I need to add is you need to tell that it is not extending the aortic root, which you are saying for, and you should tell that coronary arteries are not involved, main pertinent thing. And you should also that there is no significant hemothorax also, because it's not tending to rupture. Understood? And you should also tell that you will measure the size. Size is also important. There is no significant dilatation as of now. Understood?
Size of what?
Aorta.
Okay.
Aortic size. So because if it is an aortic dissection with aneurysmal dilatation, that's like very much urgent. This is urgent, but again, that is more impending perforation or those things. No signs of impending perforation. That was what you have to mention. Okay.
Right.
To get more marks. What you have done is good. That's not like you have done anything wrong. Okay. Okay.
Okay, I'm provided with the frontal projection of the right shoulder. And I could appreciate there is a calcification is seen in the region of the adjacent to the greater tuberosity along the insertion of the supraspinatus tendon. Rest of the joint space appears unremarkable. And I'm looking for any lesion in the bones, which I'm unable to appreciate. Visualized lung appears unremarkable. So this is likely, I would like to assess any history. If the patient is presented acutely, this could be in association with the hydroxyapatite deposition disease, or otherwise this could be in favor of frozen shoulder.
Okay. What do you do? Like
yes.
anything radiologist does these days?
Yes.
They do barbotage. Okay, remember that in
Barbotage,
UK,
yes.
in UK it is very like they do a lot. It seems they do a barbotage. They just take a needle and break the calcification.
Mhm.
Okay, I can put for the next candidate this one. Okay.
Chest X-ray frontal projection in an adult female patient. And there is a significant mediastinal widening is seen. And the heart size is unremarkable. And I'm not able to appreciate any calcifications within the mediastinal soft tissue mass. And it does not extend above the level of the clavicle. And no obvious calcification, no cavitations here. Rest of the lung fields grossly appears unremarkable, no pleural effusion. I'm looking at the bones to see any evidence of a lytic destructive lesion, which I'm unable to appreciate.
Can you
No
just
pneumo-
re-describe the mass again? Because this is a very classic film. You have to be like on the
yeah,
spot to get even a 6. So that's how it's like very important. It is all grading based. So you have to describe it very nicely.
okay,
Just think for a 15 seconds and describe to me very nicely this one.
okay. So there is a large soft tissue density mass in midline in the region of the anterior mediastinum. It has well-defined lateral margins, and it does not extend above the level of clavicles. Inferiorly, it is merged.
Because just you told it's you told anterior mediastinum or superior? Anterior, right?
Yes.
How can you say it's anterior?
The
Okay, explaining to me it's an anterior. Because you can
inferiorly.
say
Mhm.
just to be on the safer side, just tell that it is in the superior mediastinum, then describe and tell the
Okay,
explain the seal out sign.
fine. Yeah, it's in the superior mediastinum, and inferiorly it is continuous with the walls of the right and with the walls of the heart, the left and the right borders of the heart. So that is likely in favor of the anterior mediastinal mass. And the trachea is normal in position, no compression. And so my differentials would be in the anterior mediastinal masses could be thymoma, could be lymphoma, or it could be metastatic lymphadenopathy. And the patient needs further evaluation with contrast enhanced CT scan of the chest, abdomen, and pelvis, and discussion in the oncology MDT.
So your final diagnosis is this is an anterior mediastinal mass.
Yes.
Time is over.
Where is the arch of the aorta? Time is over or 20 minutes is over? I think 20 minutes, right?
Yeah.
Okay, fine.
Yes,
Where is
I'm
the
not,
arch of the
yeah,
aorta?
I'm not able to appreciate. Yeah, it is silhouetting the arch of aorta. So it could be posterior. It's involving the
You're
multiple
digging your grave.
compartments. It's involving the multiple compartments. And that's
Okay.
likely lymphoma is possible in that case, which involve the multiple compartments.
Did you see the age?
No, 15-year-old.
Mm-hmm. So tell me the differentials.
Differentials would be germ cell tumors and lymphoma.
Lymphoma,
Mets,
okay, more or less, okay.
and
Anyways, how you have to describe it? This is a large soft tissue opacity seen in the superior mediastinum, which is silhouetting the cardiac margins on the left side, and with obliteration and silhouetting of the arch of the aorta. The lesion is extending on the both sides of the mediastinum, and the superior it is not extending to the neck, and no obvious calcification seen, and no obvious rib erosion noted, and the aortic arch, the posterior aspect of the aortic arch is seen. Descending aortic arch is seen. So this suggests a possibility of a multi-compartmental mediastinal mass lesion, which is predominantly anterior mediastinum and also in the medial mediastinum. The posterior mediastinal extension could be there because we are not seeing the superior aspect of the descending thoracic aorta. Okay, that's how you have to describe everything in one go.
right.
Okay, so I'm giving you, because first you are telling anterior, that's why you should not come into the anterior only. You have to tell superior. Understood, right?
Right.
Okay, scroll through.
Okay, so contrast enhanced CT scan of the chest again confirms the mediastinal mass, anterior mediastinal mass, which shows foci of calcifications within. And okay, multiple thyroid nodules. Again, I'm scrolling down. Okay, this is seen displacing the vessels, the branch of the aortic vessels, and compression over the bronchi and the trachea as well. So looking at the calcifications, I'm more in favor of a germ cell tumor.
Okay.
And
Or teratoma is very classic, right?
yes.
Teratoma, you have to tell it in this case because so much amount of bulky, chunky calcification is there. So you have to tell teratoma. Okay. This is a teratoma. That's how the CT helps, right? Because the calcification part we were not seeing on the chest X-ray and all. And also you have to comment on the tracheal compression and all. Okay. The patient might require intubation and all those things. If you say, you'll get more additional marks. Okay.
Right.
Okay, so this were your cases. Anything cases I told which we'll discuss later? Yeah.
Yeah,
Okay.
left iliac fossa pain.
Left iliac fossa. So that's a test of just seeing it. Okay. Now, can you see anything?
Oh, this is displaced IUCD.
Yes. Okay. It was there. Left iliac. I think I pointed it out very much. Yes, it is a bit difficult. For us also, the patient had just come for abdominal pain. Ultrasound was normal. Then we did CT. Then we found this. Understood? You can see this?
Oh, I ignored this.
Yeah, that's why. When the examiner is pointing it to a very specific thing, just look at that site. Okay. Because there was no adhesion formation or obstruction and all, it was very easily to miss. So this patient had to undergo lap to remove this. Open surgery rather, not even lap. Okay. That's why I was helping you with this one. Coronal. Coronal, you can see it nicely. And the patient wasn't aware of it. She forgot that IUCD was placed also. You can see this?
Yes.
What are the complications? This can damage the vessels, which is very less likely, but most likely it can cause adhesions leading to obstruction, bowel obstruction. Okay. That is
Right.
this was the case. It is just matter of like finding it. This one you were like right, you did well, but to get more good marks, you have to be more specific in these cases like this which have what is this? Anything you can make out? This
TB, low signal intensity
no.
foci.
Why are you saying TB? It's so classic case. You are from India only, no, Ruby?
Classic.
You are from India?
Pakistan.
Pakistan. Pakistan में भी रहता है.
Same region.
What is this? This is Colex. This is the NCC, neurocystic cirrhosis. Can see this?
Okay. Yeah. Right.
Okay. These cases you should not miss.
Assist.
Yeah. What you said is not wrong, frankly. No one will fail you for it, but these cases you would get 8 or 7.5. Understood? Once you tell it is a neurocystic cirrhosis. So ideally, I have also not seen many cases with so much edema that will cause bit of a misleading thing. But which stage you see more of edema? Any idea you have of the stages?
Okay.
No. Stages of NCC. Yeah.
In the second stage.
What are the stages? First you tell me what are the stages?
One is vesicular, the first stage. Second is colloidal, and third is
granular.
Granular, and fourth is the calcified.
Nodular calcified. This is which stage? This
is second.
Good.
Colloidal.
Yeah. Okay. This is the colloidal stage when the larva is like dead and the membrane, the membrane is leaky and the fluid leaks. Then it causes a lot of edema and all. Vesicular stage, there will be no edema. Okay. Only in the colloidal stage you'll have a lot of edema. Granular stage you'll have enhancement but no edema. In nodular calcific, only calcification. Understood?
Yes.
So this was NCC. So you should not miss this. Whenever they're like pointing out of a black thing, this is a scolex and this is the separate thing. Okay.
Yeah. Nice case.
And any other
And
case?
sorry, Dr. Aejaz, what can be differential which we can offer in this, like
Same thing.
tuberculosis?
What she has told. Yes, tuberculosis, metastasis, and all. But after telling all those three things, metastasis, abscess also is a fine thing. After telling all those things, then you should say. But
basically, the edema is too much. I mean, for
exactly.
cysticercosis.
Yeah, but yes, this can be there, right? Edema, because there's a lot of leaking membrane, so it's an edema.
Yeah.
So it's okay. Like it's not wrong. But at the end, you see, she will not fail, or she'll get like 7 or 6.5. But to get that 7.8, which matters because of the rapids. Rapids is unpredictable. So this helps in such cases.
Thank you. Thank you. Yeah. And the other thing I just wanted to clarify regarding the Stanford classification, which you mentioned. So as far as like we can think of, Stanford A is anything involving ascending aorta and proximal to subclavian region, isn't it?
Yes.
And then they are saying if like if aortic arch is involved, then it is part of Stanford A.
Means in this case, ascending aorta was involved. It was crossing the arch of the ascending. The aortic root was not involved. That is what I was saying.
So ascending aorta was not involved in that case.
Ascending aorta, the part of it was involved. You can see.
Aortic arch and part of
aortic arch and the part of the ascending aorta was involved. Yes.
Right. Okay.
And I know this case because this patient, if interesting, I'll just show you. Anyhow, you have like 1 minute extra. So where is that? Okay. It is already open. No, I closed it. I'll show you what surgery was done. This one, yeah. Okay, you can see this. This is the graft. It was not a graft. It was spaced by an open surgery. You can see the screen.
Yeah.
Okay. If you want just for additional knowledge, this is called as a frozen elephant trunk graft.
Right.
Okay. If you want just for it, okay, because it was involving this one. And what happens the frozen trunk, just for additional knowledge, is that the additional graft is just freely placed within the descending thoracic aorta. So later, because this is a very long segment aortic dissection, so more chances of it extending distally. So they will just leave an additional graft so that when it extends distally, they can go endovascular through a vascular surgeon. He goes endovascular and again
repair it.
What do you say? Yeah, repair it instead of opening the aorta again. Okay.
Yeah.
Just remember it. And it was good from Ruby to see that was a subclavian artery was thrombosed. That was also very important. Okay, that will fetch you additional marks.
Yes, thank you so much. Thank you.
No problem.
So we do have the last candidate, Dr. Waleed. Are you there?
Yes, Dr. Asad. How are you, Dr. Asad? How are you, Dr. Aejaz?
Yeah, we are good. We are good. Thank you.
You guys must be tensed. I hope these are not very difficult cases. I did not. I put an intermediate level cases, not like quite easy. Okay, don't get worried. Okay.
Okay. This is a frontal chest radiograph of a skeletal immature patient revealed. There is extensive surgical emphysema noted involving the whole chest wall. There is evidence, I think, of in case like that I am searching for any fracture ribs, which I could not appreciate clearly in this view. There is endotracheal tube noted, which appear low in position and going to the right main bronchus. So I inform referring physician for repositioning. Right central venous line also noted in a good position. I am suspecting about the possibility of pneumomediastinum, which is high in this circumstances. Lung fields is also decreased evaluation in the presence of the marked surgical emphysema. I would also nasogastric tube noted in situ. I would confirm my finding to the referring physician and correlate with history of the patient for the possible trauma patient and recommend for enhanced CT for further evaluation of both lungs and the mediastinal vascular structures.
Okay. You told everything, but you missed something else. Just see at the lungs again. What will happen when there is what has happened to the ET tube? It is low, right?
ETT endotracheal tube is low in position
Yeah.
in the right main bronchus. Nasogastric tube good.
So what will that cause?
There is, I think there is soft tissue noted in the left hilum, suspecting that partial or complete collapse of the left upper lobe due to the malpositioning of ETT.
Yes, that you have to mention. Okay, you should not miss that lung
Yeah,
collapse.
but yeah, that's
There's
right.
so many things. That's why it is tricky film.
The presence of the presence of surgical emphysema make it hard.
Yeah. Okay, scroll through, please.
Can I request for remote?
Sorry.
Okay, I request now.
Yeah, you can do it.
Up and down, right?
Yeah.
Okay. I will take a look first. This is axial CT of the abdomen and pelvis with oral and IV contrast noted. The prominent finding in this study, I could appreciate that there is evidence of hypo-enhancing segment. Yes, here, hypo-enhancing segment of the right kidney. I am tracing it now. It appears cortical. I will check the renal artery. The renal artery appears to be okay. The renal vein this is not the phase to evaluate it, but I would, in my routine practice, I would like to evaluate in portovenous phase to exclude the possibility of renal vein thrombosis. This is going with renal infarct on the right side, with review of other vascular structures. In the pelvis, good. I go back for the renal, left renal. Sorry, it is still jumping.
No, but I'm waiting for you to conclude the case.
So in conclusion, depending on the arterial phase of this study,
this is arterial phase. This you can see the aorta, it is enhancing very nicely, right? This is arterial phase.
Yeah, I'm telling that.
So you want the venous, you want the venous phase? So for venous infarct you're suspecting, huh?
Yeah.
Okay, just a second. Okay.
In this portovenous phase, sorry, scrolling is not working.
Okay, I will
So,
not waste
so
time.
the main
Venous
finding
phase is fine. Venous vein is fine.
yeah.
Arterial phase, just have a look at it again on the right side. It's a renal infarct or a pyelonephritis? What, or like, how do you differentiate both?
I think it is a renal infarct because it is a wedge-shaped area of almost non-enhancing. However, there is no evidence of cortical. Sorry, it is not going. There is no evidence of cortical. I think there is evidence of cortical rim noted. So I am suspecting of infarct more than.
Where is the cortical rim?
Just a second. I go back.
And what is a cortical rim?
Cortical rim is the enhancing area under the capsule.
Okay,
it is just going up.
it's okay. Just a second. Okay,
I
only
think
you tell me. It is
here,
there?
yeah, I think here in this.
Okay, it's a enhancing area of a cortex because from the capsule because of
from the capsule because of obstruction of the main supply to this infarcted area. In the other hand, pyelonephritis will be striated and not going like that. So in a case like that, I will suspect to echocardiogram to exclude the possibility of shower of emboli. I will inform the referring physician about that and recommend also for involvement of urology team for renal functioning, and the interventional radiologist may be consulted about this case if there is management could be done within this case.
Great. Okay, you'll get 6.5 to 7, but the point is, you can see what is this? You can see my arrow, right?
Yeah, I see.
What is this?
I see it, but it is filling defect. Yeah, but
it's a renal infarct, right? Segmental renal infarct. See,
yeah,
it is
right.
corresponding to the side also. Posterior, this is
Right.
the anterior segment into the posterior segment.
I get confused about it may be venous, arterial, and something.
Vein, so always we need to follow it up. We do not see. This is the vein. You can see. This is the vein. This is fine. You can see this one, right?
Yeah, because
this is the anterior segment.
Yeah. I think here it is communicating with the vein, so
yeah, no problem, no problem. In exam we cannot be 100% right, but what you have told is very good. No point, no problem. The thing is, just tells it is a segmental infarct. What you have told capsular rim sign, it is not always seen. In this case, I felt it is not seen. That capsular rim sign occurs not because of obstruction. It occurs because the capsule of the renal parenchyma is supplied by a capsular artery, and that capsular artery arises from the main renal artery instead of the segmental artery. Okay, so that's why it is spared. So you'll have this rim of capsular enhancement. If it is seen, it is very much suggestive of renal infarct. In this case, why it is not pyelonephritis is clinical features. You should ask the patient: fever, pain. Understood? Renal infarct will be very acute. In renal pyelonephritis, they'll have patient will have burning micturition, all this. You will tell I'll correlate with the clinical features. But considering the and pyelonephritis will not occur like this. The half of the kidney is gone. You can see, right?
Right.
So it will not occur like this. It will occur more of wedge. Renal pyelonephritis is also wedge shaped. Don't worry about that. Both of them are wedge shaped. Only thing is the phase, because this is not the nephrogram phase. This is the arteriogram and partly nephrogram. And the other thing is the capsular rims and what you have told. Okay, and the clinical features. That's how you differentiate for the discussion purpose.
Okay.
Okay. Okay, you can scroll, please.
I'll take a look first. This is axial CT of the abdomen and the pelvis with IV and oral contrast refilled. There is area of fat stranding noted within the left iliac fossa with fat density noted inside at this region. This is going with local inflammatory process at this region. I will examine the rest of the exam to see if there is associated pathology or it is the only one. I couldn't appreciate any other pathology in this exam except the left iliac fossa fat stranding with fat density noted inside. This is going with epiploic appendicitis. I would correlate with patient clinical history and inform the referring physician about that to start treatment, which depends on conservative treatment with non-steroidal anti-inflammatory drugs.
Any other differentials you can think of? Why any other differentials?
Other differential for this, something like that would include diverticulitis. However, it is less likely because I couldn't appreciate any diverticular at this region. Mesenteric infarct also would be included in my differential. The ostration of the colon is not so good, but in my routine practice, I would correlate with sagittal.
I think you should stop scrolling. The examiner will get irritated generally.
Okay, sorry.
Okay, don't scroll.
I am just going to see the whole colon because I am feeling that the colon is not.
No, you were telling about mesenteric infarct. Why it's not a mesenteric infarct? That's what I was asking.
Because of the
or
position
an omental infarct. That's what I think you meant. Omental infarct.
Omental infarct, yeah. Because the position which is classical with presence of fat inside, also classical for epiploic appendicitis.
Okay. Omental infarct is generally is more larger in size. Okay. The other things what? Okay, I'm just telling you in between so that again you don't forget. Here, you know what is the cause of epiploic appendicitis? Any idea?
Torsion of epiploic of the colon.
Torsion, and the vessel which is supplying that epiploic appendicitis that gets thrombosed. Okay, you can see here this density inside. This is the vessel. Okay, this thin string thing you can see, right? That's the vessel that gets thrombosed. Okay, that is very classic of epiploic appendicitis. Okay. Omental infarct usually it will be big and it will be very big and all.
Okay.
And that is usually on the right side. That's what they say, but it's not very important. Just remember, usually in the sigmoid, epiploic appendicitis is very characteristic and very important. What they want is the management. Nothing has to be done. Okay, what you have told already.
Okay.
Okay. You can scroll.
Okay. This is ultrasound.
Yeah, that's it. Yeah.
This is ultrasound of both testicles. The right one appear to be hypoechoic. No, this is the right one. Left is good.
It's okay. It's okay. Don't worry about it. You are seeing something. Tell me. Describe that. Right or left?
This is right extratesticular lesion noted. I am suspecting at the region of the epididymal.
Describe the lesion. Describe the lesion. Yeah.
Which appear soft tissue with punctate echogenic foci inside and appear to be capsulated. There is evidence of posterior acoustic enhancement, suggestive of possibility of